evaluated.
Okay, sir.
Okay, sir, you are now live on YouTube.
Okay, sir.
You can start now, sir.
Yeah. Good morning, everyone. I'm Dr. Mohan. I'm final year senior resident critical care medicine at AIMS Jodhpur. And last week, as you know, we have discussed some basics of transcranial Doppler. Now, today is the turn of looking at advanced applications. So, as I told in the last lecture, it would be a problem-based lecture discussion. So, I've tried to include as many real cases as possible, which I have encountered during my ICU rotations. So we would like to go ahead with this discussion. Before we do, I would like to thank Hicks team, Srinivas Amvedam sir and Gansham Jagatkar sir for the opportunity. So we have around 9 stories to tell, and we would like to discuss each one of it. So the first story is bubble burst and blood spill. So you would have guessed it before itself ki this is a case of subarachnoid hemorrhage. So then so we have a case of a 45-year-old male patient with a sudden onset severe headache and altered sensorium has come to emergency department, and in emergency department CT was done and it is showing thick SH and IVH. So right middle cerebral artery aneurysm was identified and it was coiled. After that, the patient was shifted to ICU and for the further management. So while the patient is in ICU, daily TCD monitoring was done. And on day 7, the following TCD is observed. So here you can see that in this TCD, this image belongs to the MCA transtemporal insonation. And we can see that the mean flow velocities are 169. And the image next to it, we have a submandibular insonation and we are getting a velocities of 36.9 mean flow velocities. So we all know that whenever we would like to look at vasospasm in MCA territory, we would like to look at the Lindegard ratio. Now, how do we calculate Lindegard ratio? Lindegard ratio is basically mean flow velocities of ipsilateral MCA artery, which is 169 here, and mean flow velocities of ipsilateral extracranial internal carotid artery. So here it is 169 and it is 36.9. So which comes to be around 4.5. So 4.5, any Lindegard ratio more than 3 qualifies for vasospasm. So 3 to 6, it is mild to moderate vasospasm, and more than 6, it would be severe vasospasm. So in this case, we have mild to moderate vasospasm. So how do we usually do vasospasm? So vasospasm has to be suspected in an appropriate clinical situation. So for most of us, the only appropriate clinical situation we most often encounter is aneurysmal SAH. So post aneurysmal SAH, we would like to screen for vasospasm. And how do we do it is once daily or twice daily TCD monitoring in the initial surveillance period. Say up till 7 days, we would like to do daily, and then depending on the velocities, we would like to come down in terms of number of times the monitoring is done. And we need to do practice traceability. So what happens is we insonate one part of blood vessel and we get some velocity, and maybe that velocity could be low, and we say that there is no vasospasm. All we need to do is that we need to understand vasospasm is a focal phenomena where at one point there is narrowing of blood vessel because of external factors. We need to find that focal point where the vasospasm is happening. So when we practice traceability, we would be able to most often pick up the right focal point where vasospasm is happening. Otherwise, most often we would miss it. So when we are doing this traceability, we would get multiple velocities. So the point where there is highest mean flow velocity is the point of vasospasm. Also, when you get these vasospasm, the velocities, mean flow velocities in the intracranial arteries, you make sure you insonate extracranial vessels for the ratios. So we would like to see whether it is basically the problem inside the cranium, or is the circulation is overwhelming from the outside. So we call it as hyperemia. So we would like to differentiate between hyperemia and vasospasm, and that is why we insunate extracranial vessels and make a ratio out of it. But more importantly, always consider hemodynamics and PaCO2 while interpreting velocities. So last time we have seen that PaCO2 will increase the velocities. So we need to make sure that PaCO2 is at appropriate level when we are testing this. So as we all know, appropriate clinical situation for most of us we have come encountered is aneurysmal SH. But then I would like to share that even in ICH plus or minus IVH, intracerebral hemorrhage with or without intraventricular hemorrhage, traumatic brain injury, bacterial meningitis, post-operative period where tumor resections are done, and also in iatrogenic cases where the sheath has been put inside for clipping, or sorry, for coiling. So then also we might trigger vasospasm. So now this is where we see what is traceability. So now in this case, what we are doing is we are looking from the distal MCA to the proximal MCA. So this is where distal MCA would start. So, and we are looking at this point. Here we have a velocities of 67.25 TA max. Now we come slightly below it, we would get a TA max of 96.19 centimeters. Now, as we go ahead, we go further down. This is where we get peak systolic velocities of 337 and diastolic velocities of 184. If we calculate mean flow velocity, this is coming around 230 odd number. So the velocities are highest here, and this is the focal point of vasospasm. So if you come down here, the velocities have again come decreased. So if you compare, this particular point to this particular point, we have got highest velocities here. So we can say that this is a point of vasospasm, and this is what traceability is. So once you put a color Doppler, you would like to trace either from proximal to distal or distal to proximal. We would like to insunate the vessel a bit by bit and find out where highest velocities are happening. So that is what traceability is. So it improves the sensitivity of detection of vasospasm. So then once you, once you insunate the blood vessel, you would get some velocities. So for vasospasm evaluation, we would like to, capture mean flow velocities. So for different arteries, we have different velocity criterias to suspect vasospasm. So like for middle cerebral artery, it is mean flow velocity is more than 120. Anterior cerebral artery, mean flow velocities of more than 130 centimeters per second. Posterior cerebral artery, more than 110. Vertebral artery, more than 80. Basilar artery, more than 90 centimeters per second. Now, what happens is when you're looking for vasospasm and you're doing daily TCDs, even a daily increments in mean flow velocities of MCA of around 35 to 50 centimeters per second would predict severity. So today we have done and we are getting mean flow velocities of 100. Tomorrow we have got mean flow velocities of 150, and day after tomorrow it is 200. So this daily increments in mean flow velocities also predicts occurrence of vasospasm and its severity. So we need to differentiate hyperemia and vasospasm. So how do we do it? We divide the mean flow velocities of intracranial arteries, ipsilateral one, along with the mean flow velocities of the extracranial arteries, the counterparts. So that's how we got three ratios. So one is for MCA, Lindegard ratio, one is for ACA, Sloan ratio, and one we got for a basilar artery, which is Sostiel ratio. So in Lindegard ratio, mean flow velocities of ipsilateral MCA, mean flow velocities of ipsilateral extracranial ICA. With this, when we divide, we get a score. And if a score of 3 to 6 is mild to moderate vasospasm, more than 6, it would be severe vasospasm. So not just MCA aneurysms, we also often come across ACOM aneurysms. So in the anterior cerebral artery, there might be vasospasm. If it happens, so we take mean flow velocities of ACA, divided it by mean flow velocities of extracranial IC of the same side. And if the score says more than 4, then it would indicate vasospasm. In the Saustriel ratio, what we do is we take basilar artery mean flow velocity and divide it by extracranial vertebral artery mean flow velocities, and score of more than 3 indicates severe vasospasm. So now, as I told, we often come across aneurysmal SH, and the aftermath of it would be vasospasm, delayed cerebral ischemia. Now, we have come across a case in our ICU where we had a 26-year-old male patient. He had, he had a subdural hematoma with mild sulcal SH. So initially he had good GCS, but then his GCS has deteriorated. So then what happened was he was taken for decompressive craniectomy. Post decompressive craniectomy, he was shifted to our ICU. Day 2, he was extubated because of full GCS, but then day 3, he again worsened. Then day 4, dip in GCS, new onset of focal seizures we had, and then new onset of deficit hemiparesis we were getting. So what we have done is we have got a CT scan done. CT scan didn't show much of changes except for the post-operative changes on the operative side. So then we had suspicion what it could be. So then when we have done this transcranial Doppler, you could see that TA max is around 227. So mean flow velocities of MCA here is 227. Whereas here it would be somewhere around 30. So our ratios were coming more than 6 in this particular case. So then once we have seen this phenomena, we quickly called intervention radiology people. They have done a CCT, then they have seen that there is a vasospasm. So then they have taken to DSA. So in DSA, you can see that here, this part is where there is a decrease in the diameter of the MCA. So this is the part of vasospasm that has happened. So once they've seen this, that there is a vasospasm, they've given intraarterial nimodipine. And also once the patient has come back, we have started enteral nimodipine. We have given IV milrinone. We have kept MAP of more than 90, and we have done regular TCT surveillance. By doing so, by day 7, the patient has improved in terms of GCS. The focal neurological deficit has improved. We have extubated the case, and patient was shifted to ward and then to home. So the last update we had is that the patient is functionally not dependent on the family members, as well as they have taken him to the cranioplasty. So for us in traumatic brain injury, the most important thing is to manage as many secondary injury as possible. So vasospasm would be a kind of secondary injury which we need to suspect and manage if it happens. And we didn't find a lot of good guidelines as in how we manage vasospasm after traumatic brain injury. So we have followed the protocol of aneurysmal SH, and we have got a good result. So what I would like to share with the audience is that vasospasm after TBI has an incidence of up to 40%. So it can happen when there is a coexisting SH. Sometimes it can be seen without SH as well. Most often MCA and basilar arteries are involved. Onset and duration of vasospasm are variable. So many of them, they say that vasospasm occurs much earlier than aneurysmal SH, and it is short-lived when compared to aneurysmal SH. But many case reports report variability in onset and duration. Also, majority of the vasospasms are mild to moderately severe, but in our case, it was kind of severe, causing neurological deficits. So up to 16% in the literature developed neurological deficits. So when we compare it to the aneurysmal SH, traumatic SH is kind of relatively mild to moderate in severe, but then we have to take care of it. We need to be aware of it and we need to screen for it in cases where deterioration happens and your CT shows not much of any changes. So this is vasospasm after traumatic brain injury. So the next case we have encountered was in TB meningitis. So we had a young male who had on day one, patient presented with altered sensorium. CT scan was done. Patient had left-sided MCA vasospasm and MCA territory infarcts. So the next day, the GCS has dipped even further, and repeat CT scan showed even involvement of right MCA as well. So then we have done at that point of time ultrasound, and we have done this vasospasm check. So here we can see that TA max is around 313, and after therapy, it has slightly come down. And this is a TOF image from MRI. You can see that this is carotid siphon. It is coming like this, and this is giving rise to MCA. And here you can see that there is some kind of vasospasm that is happening here. So now we need to understand that more often in TB meningitis, it would be a vasculitis reaction, but initial stages, it would be vasospasm. So the question is, if the velocities are very high, should we treat it? Should we treat with enteral nimodipine or not? Should we give milrinone or not? In this case, we have given, but we have not found a very good success. Although velocities have decreased, but they have not decreased much. So the question always remains, once TB meningitis happen, how do we protect them from infarcts is a big deal. So maybe if we can screen for increased velocities way before, then maybe we might be able to bring down the infarcts. So this is an area of active research. We need to see what our research says in the future. So, but then, so they, many people embrace transcranial Doppler in the management of vasospasm, but there are many literature which goes against the utility of transcranial Doppler in vasospasm. That is primarily because apart from MCA and the vasospasm in MCA, rest other vessels, they are not much sensitive because of various issues. So if we take anterior cerebral artery, whenever there is a vasospasm, because of anterior communicating artery, the velocities could be falsely elevated. So we actually don't know whether they are they are truly elevated or falsely elevated because of flow diversions via ACOM. Now, even in posterior circulation, there are a lot of anatomical variations. That anatomical variations cannot be fully seen through a transcranial Doppler. So when there are variations, it will be difficult to pick up vasospasms. And whatever we have seen, most often we pick up proximal artery vasospasm. But as we go distal arteries like M2, M3, M4 arteries, so to pick up vasospasms in those distal arteries is difficult. And the TCD has a sensitivity of 81%, specificity of 96%. But the point is that the negative predictive value is 69%. So most often what happens is if it is vasospasm is present, we can reliably say that vasospasm is present. But if the velocities are normal, we won't be able to exclude vasospasm reliably. And there are a lot of debates saying that, okay, fine, you have told that vasospasm is there and we are managing vasospasm, but it is not translating into the better outcomes. So now why do we bother much about vasospasm? Because now we know that for delayed cerebral ischemia, a lot of other factors are there. So there is spreading depolarizations that actively take part. So apart from this vasospasm, the other phenomena is also play a role in delayed cerebral ischemia. So why are you so much bothered about vasospasm? So we have a very good paper in Neurology Journal in 2024. So where they have done a prospective study and they have seen whenever there is an aneurysmal SAH and there is a DCI, so they've collected all the data and they try to see whether it is territorial infarcts, non-territorial infarcts. So then they have tried to see. So at least two-thirds of the infarcts belong to territorial aspects. So whichever artery is involved in that territory, they are able to see infarcts. So at least two-thirds of cases are so. So from this study, we can appreciate that at least there is a heterogeneity in DCI. So we cannot label that, okay, DCI doesn't happen because of vasospasm, or treating vasospasm is not giving us results alone, because DCI is a heterogeneous phenomena. We need to phenotype these DCIs, and based on that, we would know much better about whether it is more contributed by vasospasm or whether it is contributed more by a spreading depolarizations. So this is all about vasospasm. And then the next story is all about traumatic brain injury and raised ICP. So we had a 50-year-old male patient with alleged history of road traffic accident. He was brought to emergency department. CT was done. There was a small right frontotemporal SDH with small temporal contusion. Now this patient's GCS was M5. So the patient was seen by neurosurgeon and told, okay, let's do a conservative management. But then once the patient has come to ICU, we have done a TCD. And the TCD for MCA shows that the end-diastolic velocities are 16.83, which is less, and a pulsatility index of 1.69. So what it tells is that already the raised ICP has set in, because we are able to observe that the end-diastolic velocities are less. So there is a cerebral hypoperfusion that is happening, and the pulsatility index is elevated 1.69. So that cerebral hypoperfusion is because of raised ICP. So with this data, once we admit a case of traumatic brain injury and we do a baseline TCD, it would give us a fair idea as in how the patient's trajectory would be, clinical course would be. So in this case, we have aggressively managed, even though it is a small SDH with a small contusion. These are very tricky to manage because contusions, they tend to develop into surrounding edema and they cause raise in ICP. So aggressive osmotherapy was given for this case. So then we need to understand that now we had recently released Brussels consensus for non-invasive ICP monitoring for the care of traumatic brain injury. So we all know that for till now, invasive ICP monitoring is the gold standard. But then we often don't practice invasive ICP monitoring for various reasons. So we all were wondering, including myself, I was wondering, what if ICP, invasive ICP monitoring is not there? What would we do? So then a beautiful set of guidelines have come, and the guidelines, the gist of the guidelines is that, so as of now as well, invasive ICP monitoring is gold standard. But if invasive ICP monitoring is not available, you can go ahead and pursue non-invasive methods. And the non-invasive methods they have suggested or advised are pupillometer, TCD or TCCD, or ONA and ONSD. So these three things can be used. And they say that whenever you are using non-invasive methods, use at least two different modalities. So even though many of the centers do not have a pupillometer, we can use TCD as well as ONSD. We can combine these two non-invasive modalities and we can monitor ICP through it. And for them, serial assessments are required. And when it comes to TCD, a combination of pulsatility index of 1.3, more than 1.3, with a diastolic velocities of less than 20 centimeters per second can potentially say that, okay, this patient might be having a raised ICP. And the more important thing is these non-invasive ICP monitoring techniques can be used to escalate a therapy or wean off therapy. So say that we have a patient where osmotherapy is being given and the patient is not responding. So we can increase the dose of osmotherapy, or maybe we can switch to other modalities of lowering ICP. So with this, in our patient, we have pulsatility index of 1.69 and end-diastolic velocities of 16.83. So as per the recent Brussels recommendation, this patient uh, is in a situation of raised ICP. So then how would we use a TCD for a non-invasive investment of assessment of ICP? So here we can use pulsatility index. So here there is a formula. ICP is equal to 10.93 into pulsatility index minus 1.28. So mm, so this is formula where we can use pulsatility index, substitute it, and then get a ICP number. Then there is a Zoskin's formula for non-invasive cerebral perfusion pressure. So initially we calculate cerebral perfusion pressure. So we calculated by arterial blood pressure, diastolic pressures, mean flow velocities plus 14 mmHg. So once we get cerebral perfusion pressure, we we subtract it with the arterial blood pressure. So that's how we get the ICP. And there are various mathematical models which uses artificial intelligence, data analysis techniques to use both TCD velocities, continuous TCD velocities, and arterial blood pressure monitoring. These are advanced things which we often don't get, at least in our centers. So we often use a pulsatility index based and Zoskin's formula for non-invasive assessment of ICP. And so now most of us think that, okay, the patient has traumatic brain injury, the patient had raised ICP, we have done osmotherapy, we have sedated him. Now still there is a raised ICP. Okay, let's call neurosurgeon. There is a dip in GCS. Now neurosurgeon comes and takes the patient for decompressive craniectomy. Now the question comes, okay, now the decompressive craniectomy is done. Now there is no issue of raised ICP. So it is a myth that ICP does not rise after decompressive craniectomy. ICP do rise. So make sure that you see case by case basis and stop osmotherapy. Because in this case, what we have found was this is from one of our patients. We can see that it is done on 17th of November 2024. In the morning, we have done TCD. This is after post-decompressive craniectomy. So here the velocity waveform is normal. Mean flow velocities are 81. Pulsatility index is 0.91. Though the same day post-decompressive craniectomy, 17th of November 2024 in the night. So again, we have done TCD and we have seen that there is diastolic reversal. So now this is a raised ICP waveform. And what we have done is we have aggressively given osmotherapy. So the next assessment we have done on 18th of November, 9 o'clock in the morning. So by virtue of osmotherapy and sedating the patient, taking care of all other variables, we have again got on normal waveforms with TA max of 74, but this time pulsatility index of 1.31. And by evening 7:55 of the same day, again we have got a reversal of diastolic velocities. Now we call this as oscillating waveforms. So we got this raised ICP, and unfortunately patient could not be saved despite a decompressive craniectomy because of lot of edema that has happened, which we are unable to control. And neurosurgeons said that doing a decompressive craniectomy on the other side would be futile for this case, and unfortunately we couldn't save this patient. So in these cases, in whenever decompressive craniectomy happens, uh, the traditional way to look at the craniectomy site is to touch the craniectomy site and see how it is, whether it is lax, tense, full. So then the surgeon understands that, okay, things are fine with it, and post decompressive craniectomy complications are not happening. But then, as a critical care physicians, we have our own way to do it, and our favorite tool is ultrasound. So in this, what I have done is I've used a linear ultrasound. Now that the flap is not there, the skull is not there, what I've done is I've used a linear ultrasound to see what is beneath the surface. So you can see a beautiful surface of the brain with gyri and sulci, and this particular white area is the edema. So I'll show it to you again. So this is the normal part where the black part is there, and this is an abnormal part, white color, and this is edema. So uh, this is something we are trying to understand whether we can use a linear ultrasound in the post-decompressive craniectomy patients to see whether there is edema or not, and any complications are happening, new hemorrhage that has happened or new edema that is occurring, and then titrate our osmotherapy, stop it or continue it or increase the dose. So, such decisions I feel can be taken by looking at the utilizing the linear ultrasound. This is we are doing say an observational study on this, and then we would like to see how the results would be, whether it would be useful or not. So then the next one. So with the linear ultrasound, what we are able to see is only one half of the brain. So the side of brain where decompressive craniectomy was done. So we are looking at the problems beneath the surface. So whether there is an edema, new hemorrhage, how things are. So we are looking at the site of decompressive craniectomy. But many a times, the new problems can happen on the opposite side of the brain. Okay, so suddenly it has been decompressive craniectomy has been done and the pressure has been relieved. So in the opposite side, new hemorrhages can develop. So here, what we are using is we have used a phased array probe and we have put it at the decompressive craniectomy site so that we are able to see the opposite side as well. And you can see it's like the brain is breathing. So, I mean, like we can look at the opposite side of the brain as well. And also if we tilt, we can see the posterior fossa also. So the anatomical detail would be as great as CT scan. But then the problem with the TCD and cranial ultrasound is it can just give you an idea and you need to confirm it with the CT scan or MRI whenever there is a doubt. So these two things are something which we are trying to do in our post-operative cases and try to see how the patient's clinical course is. Now the next story. So now what happened was this patient was a young male, 25-year-old male, again road traffic accident. He was brought to ED, but it was a delay transportation. So the CT showed extensive right frontotemporal SDH with multiple temporal contusions. Even at the presentation in the ED, the patient was E1 VTM1 and the patient was shifted to ICU for conservative management. Predominantly, we want to maybe we want to take the case into the ICU and then manage it because not just for the conservative management, also such patients will become a potential organ donors. So we have taken this patient into the ICU and we have started our conservative management. So here we have done TCD and all you can see is systolic spikes. So almost nearing a cerebral circulatory arrest. Now, brainstem death is a clinical diagnosis. Whenever we are unable to come to a diagnosis of brainstem death clinically, we use transcranial Doppler as an ancillary test. So what TCD tells is that it is a cerebral circulatory arrest. So it doesn't give you a clinical diagnosis. It will just tell that the circulation has ceased in the brain. So how do you do it? Long back, we have a guidelines. So this guideline says that TCD should be used as an ancillary test and it should be used whenever the clinical examination is suggestive of absent cerebral and brainstem functions. So how would you do this is an experienced operator would do two examinations 30 minutes apart. In each examination, he would assess intracranial circulation as well as extracranial circulation. So in intracranial circulation, say if he is looking at MCA, so that MCA, if it reveals oscillating pattern or a systolic spike or absent flow signals. So this is the systolic spike which you are seeing. So this is the systolic spike, and previously we have seen this is the oscillating patterns. So if you would see oscillating patterns or systolic spikes uh, in bilateral intracranial arteries as well as bilateral extracranial arteries, then that is suggestive of cerebral circulatory arrest. So next time, if you do a transcranial Doppler without taking clinical context, then things might prove disastrous, because we had recently come across a case. So we have we have a case of pontine hemorrhage. So here in ultrasound you can see nice pontine hemorrhage, like hyperechoic structure. This is where pons would be. Now this circular structure has replaced the beautiful like butterfly shaped structure which was midbrain. So the hemorrhage has been all over through the pons. Now on clinical examination, the patient did not exhibit any brainstem functions. So clinically, we have taken the patient to be a brainstem death. So this is her ultrasound. This is the patient's ultrasound picture. Now, when we have done a transcranial Doppler, the velocities are absolutely fine. So the MCA velocities are 82.76. Even the vertebral, the posterior circulation. Now we say that okay, the pontine hemorrhage is in the posterior circulation. Maybe when you are doing the ICP has not been increased so much that it would affect supratentorial circulation. But what happened is even in the infratentorial circulation, vertebral artery is still showing good velocities. So, I mean, like what we need to understand is TCD should be used in a clinical context. So if we use it in an isolated way and try to tell that this patient has some issues, so then we might go wrong. And this is one classical example where in posterior circulation there is a pontine hemorrhage and velocities are normal. So the next story, we have a stroke case. A 60-year-old male with history of advanced head and neck malignancy was brought to emergency department because there is an excessive bleed in the tracheostomy. There was a left carotid blowout, and patient was immediately taken to OR, and ENT team has managed. So during this process, the patient was operated, or his carotid artery was manipulated. So the left carotid artery was manipulated, and then we have found this in the post-operative arena. We have done TCD, and we are able to see a distal MCA flows and some ACA flows, but we are unable to see a M1 flow. So this patient had a right hemiparesis, and there is a M1 occlusion that has happened. So at any given point of time, if an experienced sonographer has seen velocities on one side and has not seen velocities on the other side, and in the clinical context of hemiparesis, we can safely say that, okay, there might be a large vessel occlusion. So whenever there is a stroke, we can many a times get a large vessel occlusions diagnosed in the ultrasound, but then the standard of care is CT angio or MR angio. Then we can assess collaterals. We can also see whether the thrombolysis have worked or not. So we have a criteria called TB criteria, and also we can look for complications of thrombolysis. So many a times we give thrombolysis, there would be a hemorrhagic transformation or a cerebral edema. So in those cases, we can actually look for the complication, and also we can work up for the cryptogenic stroke. So cryptogenic stroke is something which often occurs without a identifiable major cause, most often in the young patients. So in that workup also TCD would be helpful. So how we would see, so this is TB criteria, thrombolysis in brain ischemia criteria. So what we do is before thrombolysis, we would like to take a baseline transcranial Doppler, and we would like to see how the flows are. And after thrombolysis, say 3 hours after thrombolysis, we would again do TCD and see how the velocities are. Now, if the velocities have improved, then the thrombolysis have worked and patient would be having a good outcome. So the grade 0 to grade 5, as the grade increases, the flows will be normalized. So say that if there is a grade 1 at the baseline, and if it has increased to grade 4, then there would be a good prognosis with the thrombolysis. So this is for the traditional TCD, this criteria is. So now they had some issues with the TB criteria where the grade 1, grade 2 are kind of indistinguishable. So then the society have developed another score, which is called as COGIF score, Consensus on Grading Intracranial Flow Obstruction. So this is usually done with TCCD, transcranial color-coded duplex sonography. In this, we have 4 grades, and they have defined what is partial recanalization, complete recanalization, no change, and worsening. So after a baseline, if it improves more than 1 grade, it is partial recanalization. If it has jumped to grade 4, this is the grade 4. So if it has jumped to grade 4, then it is complete recanalization. No change is the same COGIF grade that persists, and worsening is if it dips. So we can also, with this COGIF and TBI scores, we can see how thrombolysis work for the patient or not. Apart from that, we have collaterals. So many of times, so in this case, in our previous case, even though the common carotid artery has been handled, and we ideally expect that there is a complete occlusion of MCA as well as ACA. But here what happened was there is some sort of flow at the ACA level, and there is some sort of flow in the distal MCA, and some ACA flow is there. So then we were wondering what it could be, and the answer we found was collaterals. So we have different collaterals. Collaterals are just that our neighbors, which would help us with the blood flow whenever there is a deficit. So we have 3 collaterals: anterior communicating artery, posterior communicating artery, and ophthalmic artery. So anterior communicating artery, so there is an elevated mean flow velocities, turbulence would be appreciated, and sometimes reversal. Whereas in posterior communicating artery, often you don't see a posterior communicating artery in the transcranial Doppler, but if you are able to appreciate PCOM flow, that means it is acting as a collateral. And in ophthalmic artery, classically the flow would be above the baseline, and the flows are more often a high resistance waveform. Whereas whenever it is working as a collateral, it would turn, the flow would be reversed in the ophthalmic artery, and there would be a low resistance circulation that would happen. So this is the normal ophthalmic artery waveform, where the waveform is above the baseline. There is a high resistance waveform. But then in our case, so what happened was we have found ophthalmic artery to have a reversal of flow, and there is a low resistance waveform that has happened. So this guy had collaterals, and collaterals is what has helped him to achieve, to have at least some flows in the ACA and distal MCA. So here we could see the posterior communicating artery coming out. So this is MCA, this is ACA. This is our midbrain. Here posterior communicating artery would come, and there is a connection between this particular arterial system and posterior cerebral artery. We can see it as a blue. So this blue connection, we call it as a posterior communicating artery. So whenever a posterior communicating artery is visible, we might say that, okay, this is acting as a collateral. So then what happens is sometimes, brain takes a bubble tea. So now what happened is that, so many a times in a younger patients, there is a patent foramen ovale. So whenever there is a patent foramen ovale, sometimes the emboli can get a paradoxical route towards the brain, and that's how it can cause a cryptogenic stroke. Although there are many other causes for cryptogenic stroke, PFO remains one of the common. So in this case, what we had was, we had a elderly woman with a patent foramen ovale. She was operated for some neurosurgical procedure, and she was discharged home, and she has come to emergency department with a breathlessness. DVT was positive, and pulmonary embolism was positive. She has severe pulmonary embolism. So she has desaturation, drop in blood pressure. She was intubated, informed to IR. Then IR have taken for a catheter guided thrombolysis. So in that catheter guided thrombolysis, they have also identified that the patient is having patent foramen ovale. So then after this catheter guided management, the patient was shifted to ICU for our further management. So then what happened was on day 4, day 5, patient had some kind of headache. We got a CT scan done and there were hospitals infarcts. So then we have realized that, okay, the patient would have had a PFO and we would like to see how this PFO is working. So this is the echo we have done. So the bubble test we have done, this is the right side of the heart. So right side of heart, some bubbles have escaped into the left circulation. So at the same time, we have done a transcranial Doppler. So uh, so So you can listen a normal waveform, that is the nature of a normal TCD waveform sound you have heard. Now what happened is whenever there are microembolic signals that pass through intracranial arteries and we pick up by transcranial Doppler, we have a something called as chirping sound. So we get chirping sound, and the microembolic signals will mask the waveforms of the TCD. So again, I would play here. You can observe that the microemboli shower which is happening is covering the TCD waveforms and it is producing a characteristic chirping sound. And as it clears, you would see that the normal waveform has come back. So this is how you say that microembolic signal has is there and there is a right to left shunt. You want to grade it, you can grade it. So even if you have one microembolic signal on TCD, that means there is a shunt, right to left shunt. It is that sensitive. So the more number of microembolic signals, the more severe the grade is. So grade 0 has 0 microembolic signal. Grade 1, 1 to 10. Grade 2, more than 10. Grade 3 is a curtain effect. So the previous video which we have seen is a curtain effect where you cannot count how many microembolic signals that have happened. So this is for the unilateral monitoring and this is for the bilateral monitoring. Just the numbers differs, but things remain same. So then we had a young male and who has come to ED with one month of fever and 1 week of altered sensorium. He was even V2 M2. He was managed in ED, got a CT scan done, and it has shown a hydrocephalus and patient was shifted to ICU for the further management. So what happened in this case is once the patient has come, we have done a baseline transcranial Doppler and we found a gross hydrocephalus. You can see that lateral ventricles are dilated. So immediately we have given a neurosurgical call. Neurosurgeon has come and he has decided to put a external ventricular catheter. So then once he has done, the neurosurgeon wanted a repeat scan to see whether the catheter is in the place or not. But then the patient has just come, we need to stabilize. So what we thought is, what if we can see such dilated ventricles? Why not we can see, the catheter in the position in the ventricles through ultrasound. So that is what our curiosity has, led to this beautiful image where we can see the entry of the EVD through the lateral ventricle. We can see the entry point. So again, I would play this. You can see that the EVD is coming into the lateral ventricle. So then uh, we have we are seeing that after entering into the lateral ventricle, the EVD is trying to sit into the third ventricle. You can see this is the tip. So this is the tip. The tip is sitting just
Mohan,
in the transcript in the third vertebra. So
sorry to interrupt. Mohan,
yes, yes, sir.
how much more time will you need?
Sir, 10 minutes, sir.
Okay, fine.
So this is how we have seen EVD catheters inside the ventricles. So the next application is that once EVD is put, whether to remove EVD or not, what we are doing is uh, we are uh, we are uh, we are closing the EVD and we are seeing whether the lateral ventricles are again dilating or not. So if there is an increase in the width of lateral ventricles by 5.5 mm, then it says that there is still some requirement of EVD. And here what we have done is we had one case where the patient had TB meningitis. After that, EVD was inserted, and then the patient was stable, but then had a sudden cardiac arrest. So we have done CPR through ACLS protocol. We have achieved ROSC, and as a part of routine surveillance, we have done transcranial Doppler. And then what we have found is there is a bleed, new onset of bleed that has happened inside the brain. So the same corresponding bleed we can confirm with the CT scan. So this has taught us that ICH rarely but definitely can trigger malignant arrhythmias as well as raised ICP that can push the patient into sudden cardiac arrest in the ICUs. So apart from 5Hs and 5Ts, sometimes in neurological patients keep ICH as a cause of cardiac arrest in mind. So then, what if we can use a transcranial Doppler during CPR? So this video demonstrates that when we are doing CPR, we are able to actually hold the probe tightly and we are able to get the waveforms. So this we are with this we have submitted for a publication. So rest I was unable to put it the waveforms and all. So definitely we would discuss it further. But transcranial Doppler during CPR is what I feel is a upcoming topic. So apart from that, we had a case of 70-year-old male with chest pain brought to emergency department. He had anterior wall MI that has led to cardiogenic shock. So in view of worsening vasopressor requirements, we have put a extracorporeal support. Initially, it is IABP and later it was converted to VECMO. So when IABP was instituted, we have done a transcranial Doppler and you can see that there is a diastolic augmentation. So you can see that this is a T wave and just after T wave, you have a diastolic augmentation. So whatever is happening in the peripheral circulation is also happening in the cerebral circulation. That's how we can see in this TCD. So what happened in VECMO is that in VECMO, initially the contractility of heart is very less. So that is why we have got a waveform without any pulsatility nature. So it is a uniform waveform and unfortunately for this case, there was a cerebral edema when the heart's contractility has improved. So there is increase in cerebral edema and that has led to pulsatility nature of the waveforms and there is a raised ICP. So what I would like to convey is that VECMO and VVECMO extracorporeal supports are associated with neurological problems. And although the ELSO guidelines say that, okay, you can use a continuous cerebral oxygenation, you can use pupillometry or you can use EEG, it has no recommendation for transcranial Doppler, but transcranial Doppler can be adopted in the practice and we can see whether there are any complications or not. So then the beauty within the brain is that whatever be the external pressures, it always try to maintain the perfusion pressure in a range of 50 to 150 mmHg, and we call it as cerebral autoregulation. Also, there is a phenomena called vasomotor reactivity where the cerebral vasculature responds to PaCO2. So we see these two phenomena, how they are working, and we interpret all of this vasospasm, traumatic brain injury in the context of cerebral autoregulation ideally. But because of advanced techniques unavailability, we are not looking at the cerebral autoregulation. So we have two things, static and dynamic. Static is that you increase arterial blood pressure and arterial blood pressure will be increased and you see whether the autoregulation has happened or not. Whereas in dynamic autoregulation, what we do is it would be a transient response, a trigger we give, and we see how quickly the brain is responding to the transient transient provocation. So that is dynamic. So we have different dynamic cerebral autoregulation assessments. So we can use it with provocative measures. Provocative measures are not required. So these are the latest ones: mean velocity index and pressure reactivity index. These are the latest ones which UK are adopting, and which we actually do at the bedside is cerebral vasomotor reactivity, where we ask the patient to take a deep breath and hold. So once we hold a breath, CO2 will increase, and CO2 will cause increase in the mean flow velocities. So that's how we get a breath holding index. Mean flow velocities of maximum was minus baseline divided by apnea time into 100. The normal values is more than 0.6. If it is less than 0.6, it implies vasomotor reactivity, and the patient may not tolerate, the vessels may not tolerate more stress. So we have done. So as apnea time increases, you can see that mean flow velocity is kept on increasing. 58, 60, 65, 73. So, and then it has come down, and the breath holding index is 1.119. Vasomotor reactivity is normal. So, I mean, there are wonderful applications of TCD which we can do it at the bedside. I would request all of you to embrace transcranial Doppler in managing neurocritically ill patients, non-neurocritically ill patients. It would definitely give us more insights and help us in the management. And I would like to thank my team, my friends, my colleagues, whose inputs actually helped us to understand it much better and innovate it more. Thank you.
Thank you, Sai. And I must congratulate you and your team for the tremendous work that you people are doing.
Thank you,
And
sir.
you have kind of opened up the different possibilities of transcranial Doppler in neurocritical care. But what I understand is, well, the possibilities are endless. But I
Yes,
think you need to go through some amount of training, isn't some amount of supervision, some amount of training.
yes, sir.
So any youngsters who want to learn TCD can get in touch with Mohan directly, go through the videos. Once again, Sai, thank you so much
Thank you, sir.
for taking us through the applications of both the basics and the advanced applications of TCD in neurocritical care. Thank you very much, Sai.
Thank you, sir.
Okay.